I know that so many of you are very excited and interested in this topic, as am I. So I'm going to get started. My name is Anissa Mitchell with PMD Alliance, and I'm very happy to have with us today Jenny Nguyen, who's going to be talking to you about sleep issues and Parkinson's. But before we get started, I want to invite you to open up your chat box and ask your questions. We're going to hold those until the end of the program today. But feel free to pop those in as you are thinking about them as she goes through the slides. Give us a shout out, let us know where you're joining us from. I always love sharing with our speakers where all our audience are coming to us from. So let us know where you're joining us from. And I'm going to introduce Jenny Nguyen. She is a movement disorders nurse practitioner at the Cleveland Clinic in Las Vegas, Nevada. And she has experience in managing people with Parkinson's disease, Huntington's disease, essential tremor, ataxia, tardive dyskinesia, and dystonia. She's experienced in botulinum toxin injections for sialorrhea and deep brain stimulation programmer. So she's very well-rounded. She has a special interest and expertise in sleep disorders. And so she's going to be going over a variety of different sleep issues that can be found and experienced with Parkinson's disease. So I'm happy to welcome you, Jenny, and I'm going to pass this over to you.
Hi, thank you so much for having me. It's such a pleasure to be invited to this group. It's so robust. I mean, I think this is one of the biggest turnouts we've had for a support group. So this is amazing. I'm so excited to be here. So I prepared some slides, so I'll just go through them, and then hopefully we can go over some questions in the Q&A portion. I think that's usually really lively, and I think people get more out of the Q&A at the end. So I will start share screen, and perfect. So today we're focusing on sleep disturbance in patients with Parkinson's disease. I find that I spend so much time in the clinic focused on talking about sleep with patients that over the years I've just developed a special interest in it. Instead of just speaking to each individual patient, we always like to maybe find some ways to disseminate the information to a larger group, increasing the awareness of sleep issues. And so that way patients can bring that to the attention of their healthcare providers. So the objectives today is that we're just going to give an overview of Parkinson's disease, which is a movement disorder, review some of the non-motor features of PD, describe the prevalence and variety of sleep disturbances in patients who are at risk with Parkinson's disease, recognize the importance of sleep in neurodegeneration, communication with your healthcare providers, and then what you can do for yourself with sleep disturbance. I'm sure since this is a Parkinson's support group, we're all kind of aware of the cardinal features or the most classic symptoms of Parkinson's disease. James Parkinson described his observations of a PD patient and their motor dysfunction over 200 years ago. This is the classic picture from the book. So it's a patient with a very stooped posture, with a slow gait, shuffling, usually asymmetric resting tremor, the mass spacey, reduced arm swing, and then the stiffness, rigidity. The main features that we use for clinical diagnosis is bradykinesia, which is slowness of movement. You can observe somebody in the waiting room in our clinic or even at a restaurant. Sometimes when you see people get up to move, they're so slow getting, reaching to get their ID card out or their insurance card. So the global slowness of movement, the rigidity in the joints. So usually the cogwheeling when we check for passive range of motion, also usually kind of described as like a lead pipe resistance in your joints. The pill rolling tremor, usually again asymmetric, postural instability near falls or unprovoked falls. I usually find that to be, in some cases, more an advanced disease. If you develop like postural instability in early disease, I would say generally more reflective of atypical cases. So Parkinson's disease, over the years, it used to be known as a movement disorder because James Parkinson's described all of the motor features um, that are seen as a disability. And so it's always known as movement. But in 2022, we all know that it's evolved into a very dynamic disease. It involves multi-system. And so we have better understanding that Parkinson's disease in many patients causes more disability with non-motor symptoms. And these are some of the non-motor symptoms that we see and we talk to our patients about regularly. So primarily sleep disturbance, that's why I wanted to focus on today. Insomnia, sleep fragmentation, nocturnal motor features, mood disturbance, so anxiety, depression, and apathy. Memory changes that can take part in Parkinson's is usually dementia, hallucinations, and psychosis. Even urinary disturbance, so urgency, frequency, and overnight urination. And then as part of the autonomic dysfunction, you sometimes also see blood pressure fluctuations. For us, generally seen with more neurogenic orthostatic hypotension, so very low blood pressure. I like this diagram because it really demonstrates how non-motor symptoms of Parkinson's really affects patients. It affects 84% of people with PD. I think sometimes when you come into a general neurology clinic, we find that, patients that transfer care to us, they tend to tell us that the focus is always how's your medication working? How are your movement symptoms? What are your off times? So usually just the focus is more on their movement and motor disability. And there's lack of focus on non-motor features, which sometimes if you ask the patient, what's the most troublesome issue that brings you in today? I find that patients usually kind of bring it back to non-motor issues. They don't really tend to talk about, there's an off time in the morning or early afternoon. Usually people bring up, some sort of issues with drooling or they're not getting enough sleep, anxiety, depression. And so it's really important that we bring more focus into non-motor symptoms of PD. So a little bit about the background. As you know, Parkinson's is the second most common neurodegenerative syndrome after Alzheimer's disease. And so with the aging population, more and more people are being diagnosed with PD. I think it's just because there's more awareness of it. There's physicians and healthcare providers are just in tune with recognizing the features of it. And so more people are living longer, getting diagnosed with it. So an estimated 930,000 Americans live with Parkinson's disease, and anywhere from usually 60 to 98% depending on the literature that you are looking at, will report some experiences of sleep disturbance. Sorry, I didn't define. SD is sleep disturbance in this presentation. So again, the prevalence with sleep disturbance will usually increase in an aging population. It's defined as excessive daytime sleepiness or somnolence, insomnia, fragmentation, nocturnal motor features, dream enactment, REM sleep behavior symptoms, restless leg syndrome, and sleep disorder breathing. So sleep and brain health. So when you're sleeping, it's actually very restorative. Your neurons are able to rest and basically get rid of metabolic toxins called amyloid beta, or beta amyloid. And so when you are not sleeping well, you're not getting the deep sleep that's required for the neurons to rest. Usually there's a buildup of the beta amyloids. And so that's really common in patients with Alzheimer's disease. Is you see there's a toxic buildup of metabolic waste, right? So sometimes how we explain it to patient is if it's like your dryer. If you don't clean out the lint screen with each cycle, you tend to get a buildup. Maybe 1 or 2 cycles, you may not notice it. So if you're not getting good sleep 1 or 2 nights, you can usually kind of power through the day and really don't notice a lot of the effects of it. But I think the accumulative effect of sleep deprivation can really take a toll on the brain. Mainly the cognitive flexibility, the working memory, the delayed recall is usually what we hear patients describe is that, oh gosh, my long-term memory is great. I mean, I can remember stuff in my childhood, from when I met my spouse, dating history. Gosh, I've heard everything. But then the working memory is generally what's affected, the delayed recall. Conversations, difficulty with finding a word when you're trying to describe something, when you're talking with someone. So that's generally what's affected. And cognitive flexibility is when you're able to adapt to, different changes in the environment. If you're traveling, the different time zones, if there's any alterations in your day-to-day activities, that your brain is a bit more adaptive and still able to rest at the end of the day. And even I find like, gosh, how you perceive emotional information is affected when you're not getting enough sleep also. People are a bit more, I think they don't receive it well. It's the adaptation process that's affected. Irritability, anxiety, more easily agitated as a result of it, are all issues that you see with sleep deprivation. So the sleep is actually a key role in the onset and the progression of neurodegeneration. We see that it's an early sign of an increased risk for future development of neurodegenerative disorders. It's a result of damage to the central nervous system, so the hypothalamus, the suprachiasmatic nucleus, or the SCN. And there's more and more data to support that poor sleep actually leads to the acceleration of progression of neurodegenerative diseases, specifically Parkinson's disease. And so that's actually, sleep disturbance is actually used as a biomarker when we are looking at research in early Prodromalpd. So prodromalpd it's actually a stage where latent Parkinson's or latent PD is before clinical features of the disease actually comes forward. The long latency period can last anywhere from, 5 years to 15 years. And so sleep-related symptoms are generally seen in this period. When we get a patient in the clinic and we're using their history for diagnosis, we always ask about sleep. How long have you been struggling with sleep issues if you have had it? Do you usually act out your dreams? And so this is actually now used as a biomarker for research in prodromalpd. So REM sleep behavior disorder has been seen to convert to Parkinson's disease and other synucleinopathies such as dementia with Lewy bodies and multiple system atrophy. So dementia with Lewy bodies and multiple system atrophy is actually one of the atypical Parkinsonisms that we actually see here in the clinic. It's also considered a movement disorder because it's also with the protein mutation of alpha synucleinopathy. And so, but Parkinson's disease is the most common one. Phenoconversion is just a fancy term that patients over time well-developed manifestations of the disease. And so if patients have sleep disturbance, so in 15 to 30% of cases, it's not all sleep disturbance, I'm sorry, I will clarify that. It's usually with REM sleep behavior disorder. If you're presenting with that, longitudinal studies have shown that 15 to 35% of those patients will evolve into a Parkinson's patient within 2 to 5 years. And then when they follow the patients for longer, so from 12 to 25 years, that risk increases from 41 to 90.9%. I don't have studies that looked at, following patients for greater than 25 years, but with the trajectory of the phenoconversion risk, I think if you follow patients for 30 to 35 years, almost like 95% of cases will phenoconvert. So it's actually right now seen as the most specific clinical prodromal marker for PD. So some of the types of sleep disturbance in Parkinson's disease, it's really specific. So it's insomnia, which is difficulty falling asleep, fragmentation, waking up multiple times during the night. The fragmentation can be primary or secondary, so it could be related to Parkinson's, because we think of when your medications wear off during the night, you develop more stiffness, difficulty turning over in bed, moving your blanket up, getting in and out of bed to urinate, tremor that can causes awakening during the night, and then difficulty falling back asleep, or even dystonia. I've had patients describe dystonia symptoms, which is, increased muscle activity, involuntary muscle activity that causes, twisting of the muscles. And so that can cause cramping and pain. And so we usually see, wearing off or off times during the night that causes sleep fragmentation. Secondary causes for sleep fragmentation is usually overnight urination, so overactive bladder issues, urgency, and then difficulty with returning to sleep. I think it affects men and women. I would say it affects more men than women because of the higher risk for enlarged prostates in older men. And then excessive daytime sleepiness or somnolence contributes to this kind of a never-ending circle or ripple effect. When you have circadian rhythm disturbance and you are, awake more during the night, your sleep is fragmented, or you have premature waking up, you tend to develop, somnolence during the day, difficulty staying awake, and so you're catnapping on your recliner, and then that contributes to difficulty with sleep at nighttime. Vivid dreams. This is interesting because I find that most patients who don't really dream before or recall their dreams are now coming in and telling us, describing their dreams very vividly. They recall everything the following day, or they'll describe it to their spouse or their bed partner. And so it depends. Sometimes it could be more emotional dreams or nightmares. So if it impacts them, emotionally in some ways, that can really cause a disruption in their daytime function, because then they kind of think about those vivid dreams throughout the day too. And then RBD we always include because it's so prevalent in patients with Parkinson's disease. Say 1 in 2 patients with PD report symptoms of REM behavior disturbance. And so just more statistics with it, because it actually affects more men than women. We don't know if it's because men have more aggressive dreams or they have more violent behaviors. Usually I found this really great illustration. So, he's dreaming of himself like boxing, and so he's having a lot of upper limb movements. And women tend to be like, they're caregivers, and they're more outspoken. I would say if you're coming into the clinic, sometimes the spouse is describing their bed partners like sleep behaviors, and they'll usually report more issues with their spouse acting out of their dreams. I would say for female cases, I would think it's like underreported. It tends to involve more vocalizations, talking, speaking in sleep, rather than a lot of upper limb movements. It's very dangerous, and so that's why we always, talk about it during our course of the visit. We want to be able to address it. It's dangerous to you as the patient as well as the bed partner. I've had patients, gosh, this particular patient comes to mind because I met him very early on in the career. He came in and he told me that he was wearing a neck brace, and he described diving out of bed because he was chasing after a burglar or some sort of a home invasion or something, and he was diving and chasing after somebody, and he dove into the nightstand, and he sustained a fracture in the spine, and so causing him to have surgery. It was pretty invasive and very traumatic for him, and so as a result of that, he was really nervous with sleeping at night, and so he would just sleep in the recliner. He didn't want to have to, like, the fear of harming his wife. So I just always remember that case because it was one of the more traumatic cases. I've heard of other cases where the bed partner is struck in the face and they'll come in all bruised. And so it's definitely dangerous to you as well as your bed partner. We want to know about it so that we want to find ways to correct the REM sleep behavior disorder if we can. The gold standard for diagnosis of this is usually a sleep polysomnography, which requires a sleep study in a specialized sleep lab. We don't have a sleep lab as part of a movement disorder clinic, so usually that requires a referral out to sleep medicine, and they will usually interpret the results, and then they will also share that with us, but doesn't always require sleep polysomnography. I would say most of my patients will decline a sleep study if it's involving REM sleep behavior disorder, because just how invasive it is and the difficulty with being able to sleep in a lab. So we usually use like sleep partner report. If you don't have a sleep partner, usually sometimes family members who stay overnight might be able to say, oh, there's a lot of movement or activities during the night. I can hear it from the next room. If you have a pet, sometimes they'll describe, I go to bed with my dog in the bed with me, but then I wake up and he's like clear across the room. My sheets are tossed everywhere. Things on the nightstand are moved, but just how the disheveled the room is, or if the pets move to the other side of the room could also be used. The reason why the sleep polysomnography is really important is that if you have sleep apnea, it can really mimic the symptoms of RBD. So if we're really unsure if this is a case of RBD or sleep apnea, we would definitely highly recommend a sleep polysomnography, because if you correct the sleep apnea issues, then consequently your the active dreaming behaviors will resolve. So I just included in here some of the stages of sleep. So usually REM sleep is the deepest state of sleep. And in REM sleep, your body is supposed to be paralyzed other than your breathing mechanisms, because it's a protective way for you to protect your body from dream mentation, right? People that act out their dreams. And so you're not supposed to be, fighting anyone or chasing after your dog, diving out of bed. This allows your body to actually rest in a safe way. So overall, the stages of sleep really repeats itself. The cycle of sleep, will repeat itself multiple times during the night. I think it lasts anywhere from, like 45 minutes to 120 minutes, and it repeats itself several times. I think the sleep architecture is different for everybody, and it changes with aging. So sleep disorder breathing, I just want to touch base on this briefly, but to clarify, I don't do sleep medicine specifically. I do movement disorder. And so some of this is what we've learned because we deal with patients that experience sleep disorder breathing, but we don't treat it. And we generally don't diagnose it either, because in order to diagnose sleep disorder breathing, it requires a polysomnography that is done in a sleep lab. And so interpretation of that is generally dependent on the sleep medicine physician. And then treatment recommendations are usually like a CPAP or a BiPAP that helps with oxygenation and airflow. And so that's not prescribed by us, and we don't have it's outside of our scope. But I do want to clarify, because I've had questions in the past between central sleep apnea and obstructive sleep apnea. So central sleep apnea is the brain's failure to send a signal for muscle contraction, so resulting in no movement of the rib cage and the abdomen, which is pretty rare. But if you have sort of, brain injury, or it could be idiopathic, meaning there's no reason, we don't understand why, but you can have central sleep apnea. And then the obstructive apnea, which is more, the majority of patients are usually affected by obstructive, because it's more structural. So the result is a full collapse of the pharyngeal airway. It blocks air from, coming in and out of the lungs. So it causes out of phase movement. And I think when we refer to those terms, it's what's used to help with diagnosis. So sleep disorder breathing can also be a leading cause of sleep fragmentation, the premature waking up, the excessive daytime drowsiness. That's why we always have to consider that when we're looking at Parkinson's patients. We don't know if there's a correlation between obstructive sleep apnea and Parkinson's. I think it's highly debatable still. But I would say I do see a lot of, obstructive sleep apnea in PD. But we don't have enough data to say Parkinson's causes obstructive sleep apnea or the other way around. I think, again, there's more data to show that untreated obstructive sleep apnea or obstructive sleep apnea in itself puts patients at higher risk for dementia and dementia-related illness like Alzheimer's disease. Sorry, there's something else I wanted to say about this slide. I think the prevalence for the obstructive sleep apnea in Parkinson's patients ranges from 20 to, I believe like 40% of Parkinson's cases have OSA. So it's really important that we're vigilant in when we talk about any of the, sleep issues, is that we rule out OSA first before treating the sleep disturbance, because otherwise it's putting a Band-Aid on sleep issues when we don't really know what the cause is. I think when people see like the polysomnography in the sleep lab, it's kind of it's a turn off. I feel like patients don't want to talk about it. They are really hesitant to commit to a sleep study. But more and more data is showing that it's so important that we properly diagnose patients before we treat them. And I know the technology is evolving, and so there's computer labs that actually assesses sleep disturbance without having to wear the 20 electrodes, which is so awkward for sleeping. And they can really assess like upper limb movements. There's also like actigraphy, which is the wrist watch that can monitor, overnight activities and sleep movements. I'm not sure if it actually records like oxygenation and stuff, but I know actigraphy is really popular in research. So age-related changes and how we can kind of differentiate that from Parkinson's. It's really difficult. It's really difficult because most of our patients with Parkinson's, the median age of diagnosis of PD is, I believe, 55 or 56 years of age. and then to 80. And so because of the age range that we see PD patients in, because sometimes it may be difficult to differentiate, is this age related or is this like Parkinson's related? But some of the Parkinson's specific ones, which I went over, is more like RBD, restless legs, periodic limb movement. That's generally just seen in PD patients. And so age-related changes is usually how the hypothalamus and the SCN, so the suprachiasmatic nucleus, um, becomes less robust with aging, just as like all your body organs, um, the function becomes less robust. The circadian system also is affected. It's the internal body's pacemaker. So it regulates like physiological functions, blood pressure, body temperature, release of certain hormones like melatonin, bone remodeling, sleep-wake rhythm, rest activity pattern. This actually starts to malfunction, or not malfunction, but it becomes less flexible in aging. And so we see that patients start to develop changes in when they go to sleep, when they wake up. And this is usually independent of other comorbidities or even medications. Oops. So the recommendations that I've seen in the literature is usually if you can have the patients try to adjust their sleep cycle to going to bed earlier, and that way they can get a full night's sleep requirement. I think the Sleep Foundation and the American Academy of Neurology defines like the recommended amount of sleep for a healthy individual is usually a minimum of 7 hours. You can get 8 hours, I think that's great, but I usually would say 7 hours, and then that reduces with aging. So I feel like this slide is everything that we consider that goes through our mind as a healthcare provider when patients describe difficulty falling asleep, staying asleep, or early awakening. Is this related to their motor features that's causing them to wake up? So on the right hand side, you see slowness of movement, stiffness, tremor, dystonia, wearing off of your movement medications that contribute to your subjective sleep complaints, or non-motor symptoms, which is anxiety. Patients can describe, I wake up and then I have these racing thoughts. I think about everything that's going on in the world, news, what's going on with my disease and where this journey is heading. And so family matters, and that really can cause them to not be able to fall back asleep. So anxiety, depression, hallucinations and delusions can also, are non-motor features of Parkinson's that could cause this sleep disturbance. And then REM behavior disorder has its own category. So, and then on the bottom, we, other causes that we definitely have to consider is this, is this because of the medications that we prescribe to you that's causing you to be, you have trouble falling and staying asleep? Is it age-related changes, or it's just other comorbidities? So secondary causes like overactive bladder that might be leading to sleep disturbance. So the current trend in practice, I have this slide in here because I've used this presentation for another talk, and I think it's so important to bring up here as well, is that despite the prevalence that we see of sleep disturbance in Parkinson's, it's often actually very under-recognized and undertreated. It's under-recognized and undertreated in general neurology. It's also in primary care, internal medicine. We don't really hear like a lot of healthcare providers bringing up, like, as part of your review of systems, how are you sleeping? Did you would you define your sleep as like quality sleep? Do you wake up feeling refreshed? Do you have energy during the day? Are you really tired and foggy? Do you require naps in the afternoon? So I think it's really undertreated and under-recognized. People are tending to gravitate towards, the more important topics, such as like exercise, um, and more, eating habits and things like that. So, but I think if you sleep is the baseline, is so restorative. And so I think if we treat sleep, as a result, patients will tend to come back and say they feel a lot better. They are in better mood. They respond to their medications. Um, they can think more clearly. They have more energy. So better mood, better stamina, cognitive flexibility. There's no formal routine screening in the general population. So it could be related to, the patient provider burden, the time constraint that we have to see a patient in the clinic is just always limited. And so we always want to optimize the time. If you have concerns with sleep, definitely, make it a point to bring it up during the visit. Um, the majority of the patient population, again, usually affected is patients 60 years of age and older. So therefore, because of the age group that's generally affected, I think you might interpret it as part of the normal aging process and not disease related. So patients actually tend to, they fail to disclose it to their healthcare providers. And of course, in COVID-19 infection prevention procedures, all the social distancing, the isolation that we've seen in the past few years have really caused an uptick in the, all of the mood disturbances that we've seen across the board, as well as sleep and disturbances. People aren't able to get out and exercise as often. All the gyms were closed. The lack of social interactions and things like that that used to drive their activity and sleep pattern is really just out of sync. So the value in screening, again, I think this is just re-emphasizing sleep dysfunctions. We can conclude that it's related to a worse quality of life and really a greater non-motor symptom burden. Because it's a ripple effect. I think, again, if you don't sleep well, you tend to do poorly with how you think, how you emotionally receive information, and so leading to depression, how you interpret pain, fatigue, impulse control behaviors are also seen in patients with sleep disturbance. So early detection and management of sleep-related problems is vital. It helps patients, positively have better outcomes. I feel like it actually helps with, this is a big statement, but I think when patients sleep better, they tend to do a lot better with their Parkinson's disease. And so there's some value in it because it delays progression, right? Because if you don't sleep well, you tend to not exercise, you tend to be more sedentary, and that really impacts how your motor symptoms will manifest. The treatment for us is usually we really review the patient's medical history, looking at all of their medications. I tend to look at your medications before the visit, but when patients bring up like sleep disturbance, I'm really quick to just really assess what their current medications are and how that could be causing sleep issues. Because sometimes what we prescribe to you for movement related symptoms can really impact your sleep at night. And so reducing the dose, switching medicines, prescribing something new can really help. New medication here is if patients have already exhausted non-pharmacological treatments like cognitive behavioral therapy for sleep, changing lifestyle, then we really should consider prescribing like a sleep aid for them. And then sleep disorder related breathing, you have to consider involving a sleep medicine specialist so that they can prescribe the correct appliance like a CPAP or a BiPAP for treatment. And then again, lifestyle changes, setting regular sleep-wake times, reducing stimulus like electronic device, television, and then even creating a safe sleeping environment. As if the risk for REM behavior disorder cannot be entirely eliminated 100%, if we are able to reduce it from, 4 or 5 times a week to maybe once or twice a month, you're still having to change your sleep environment to make it safer. So maybe pushing the bed towards like a wall on your side, so that way it makes it harder for you to fall out of bed, removing the nightstand or sharp objects, lowering the bed in some ways have all been shown to help, getting a bed rail. So I'd say in summary, sleep disturbance really negatively affects quality of life. In patients with neurodegenerative syndrome, I think the ability to regulate sleep-wake pattern is really difficult. And so that really negatively impacts, all of your motor symptoms as well as your other non-motor features with mood disturbance, and everything else. And so it's so important that we discuss it. If you feel like it's not properly addressed by your healthcare providers, you should always be your own advocate and make sure you bring it up in the visit, because I think when you can bring up the issues of sleep, you focus the appointment more instead of just talking about your medications at each and every visit. Make an appointment especially just to talk about sleep, because if you find like, wow, they're not really having enough time to address all these issues, prioritize it yourself and make sure that you set time with the provider just to focus on sleep. And then the following slides are a lot of my references that you can use to review what I've said. So this PowerPoint slide will be available to you to print if you like. So I will exit out, and then hopefully we can go over some Q&A.
Sorry about that. Somehow my Zoom just disappeared to find it. So I apologize for that delay. Thank you, Jenny. I actually do have several questions that came in. And I'm going to try to put them together, ones that are similar. So I want to ask a question first about, and I saw it on one of the slides, if you could talk a little bit about periodic limb movement syndrome, because we know restless leg, and I know people that have said, they get up in the middle of the night and they walk, and that kind of helps with that urge, but periodic limb movement syndrome is a little bit different. And I wondered if you could just explain that a little bit.
Yes, you're right. Restless, I'm sorry I didn't touch more on it, because I feel like there's so many topics with sleep that I just wanted to emphasize some of the more important ones. So restless legs is definitely defined as like the classic textbook symptoms is like, wow, sensations in the legs where you have to get up out of bed. Walking helps. It's very nocturnal dependent. So usually evening time laying down is what when it starts to peak. And so it really affects people's ability to fall asleep and stay asleep. Periodic limb movement is more of lower extremity involuntary movements while you're sleeping. I think, again, I would definitely rely on a sleep polysomnography, because if we don't have like a proper report from a sleep partner, then it's really hard to diagnose, because I find that the difference between that and RBD or REM behavior is more upper limb versus lower limb. Yeah, but I always kind of just fall back on the sleep study, because that way we have the right data to diagnose the patients, and so we know how to treat them.
And I know that there were some questions and a few people's comments in regards to those who live in rural areas that may not have access to a sleep center. Is this something that can be done very well from home, from a telemedicine perspective?
Gosh, that's such a great question.
I know this is not your area of expertise, but I just was curious as if you've come across that.
That's such a good question. You're absolutely right. I think people that live in rural areas are definitely lack the resources for proper diagnosis. I think some of the developments in the field with this actigraphy, so the wristwatch, and even the iWatch now, the Fitbits. I was just talking to Anissa about this prior to jumping on, is that I don't know how accurate those tracking of your sleep is, because forgive me, but I don't know if it tracks oxygenation in sleep. And so I know it looks at heart rate, and then the sleep architecture. So how long you're in, stages 1 through 4, and then stage 5, REM and non-REM. But I think if we can develop more solid data that the the um, the iPhone, the data that we can retrieve from the iPhone is solid data to diagnose sleep, um, any sleep disorders, and we can actually use that for patients in more rural areas that lack a sleep lab. And it's less invasive than sleep studies. I think again, patients are so turned off when we suggest the sleep studies because they thinking of sleeping in a foreign bed with all these electrodes on you and being watched is actually so invasive.
And I have a couple questions in regards to sleep apnea. One, does snoring always mean someone has apnea? And are there alternatives to CPAPs for sleep apnea?
Gosh, I don't want to speak outside of my scope, but I think the way sleep apnea is diagnosed is they look at the ratios of normal breathing versus the sum of the chest and abdominal movements, and then they also look at your sleep oxygenation. So there's a lot of different factors that they look into using for a diagnosis of sleep apnea, like an obstructive sleep apnea. So I don't think that snoring alone is used as a diagnostic feature. I think they're all looking at the sum of the ratio of chest and abdominal movements, the oxygenation overnight. So if you're hypoxic, meaning that your, oxygenation is below 94% for a period of time, those are all factors that has to be included into a diagnosis.
Great. And we had a few questions in regards to the sleep fragmentation. So we know that you said around 7 hours is what's recommended. It decreases a little bit as far as being able to obtain that for restorative sleep. But can you be restored even if your sleep is fragmented? And can daytime napping help supplement the lack of sleep at night?
Wow, what an intelligent question.
Those were actually two that I put together.
Wow. I'm shocked. Okay, so I'm going to be honest, I don't know that it does. The answer to that is that if you can hit REM sleep during the day, right? Because the different stages of sleep adds up to be 5-10 minutes each in the quiet sleep, and then when you fall into deep sleep, that's usually stage 4 or 5, is that it takes a really long time to reach REM. And so I don't know how you could reach REM if you're just cat napping during the day, like 15-20 minutes here, an hour there. I think more research needs to be looked at into whether or not you can reach REM during the day.
All right. And then
that's such a great question. I definitely have to do some research on that. I'm like, wow, I don't know if anyone's looked into that.
Yeah, we always get such great questions. So yeah, so I have some more great ones. So we had some questions in regards to medication. So there was one, do PD meds contribute to the sleep disturbance? And then another, does some of the meds help the sleep disturbance at night? Like if I took more carbidopa, levodopa before bed, would that help me sleep? So I guess we're talking about two opposites, but maybe you could address those.
Yeah. So it depends. If it's medication induced sleep disturbance, we have to see what you're taking that's close to bedtime. I'm just going to throw this one out there. So for example, amantadine is it's a medication that we commonly use for freezing of gait and also levodopa induced dyskinesia. So all the involuntary movements that tends to cause, it's a stimulant. So I think that if you take it in the afternoon times and close to bedtime, you usually come in reporting sleep disturbance. So looking at your medication list, we need to be able to readjust those medications to earlier in the day. But if it's like an off symptom that you're experiencing, so like stiffness that's causing you to, turn over in bed, moving your blanket up, just to be functional in bed, that can also cause you to not be able to sleep and stay asleep. So for those cases, based on how the patient describes their symptoms, we can either prescribe like carbidopa levodopa CR, like a sustained release or control release formulation that helps that you bridge that gap for overnight and early morning offs. Um, it just depends on, but most of the Parkinson's medications we use, you're correct. It causes a lot of drowsiness. I think it's like the first thing that's written on the label when you receive it from the pharmacy is that this causes drowsiness. Be careful when you're operating motor vehicles and things like that. But in some patients, they actually have like a paradoxical effect. It's really patient dependent. I've had patients say, wow, when they take carbidopa levodopa, they feel more awake, which is unusual.
Mhm. So along the lines of medications, there's been a few questions about taking different things to help aid sleep. So one person asked about I'm not going to say this right, doxylamine sukinate as a safe and long-term treatment, an antihistamine. Are you familiar with that?
I'm
And
not
then
familiar
another
with the
person
first one, but for example, like things like Benadryl, I have a lot of patients that take Tylenol PM. I think the PM portion of it is Benadryl. So, or any anticholinergic, because anticholinergic, the primary side effect is drowsiness. And so, if you're using it for sleep, to induce sleep and to stay asleep, that can affect memory. So if you're using Benadryl for years, when we hear that, it's like one of the first things that we would recommend to take off, is because things like that can definitely impact your memory in the long term. So it just depends on the medications. But melatonin is a hormone that your brain already produces, and so if there's an irregularity of it in aging process and in Parkinson's patients, providing that extra dose of melatonin can help you get back into REM sleep a bit easier. And it's non-habit forming, it's over the counter, it's readily available. Some patients, respond to very low doses, and some patients require higher dose. But I think it's a lot safer to take versus like an antihistamine or an anticholinergic medication.
And I know others have asked about different herbal supplements that are out on the market that have a variety of different things in them. Would you recommend that they just discuss it with their treating healthcare providers to make sure that that's safe? I know sometimes there's claims that they will help with sleep, and they might, but there could be contraindications.
I agree. I think herbal supplements are so tricky because more and more people are bringing in, these supplements that you can purchase like online or in other countries. And to be honest, sometimes when people bring them in, I'm like, I'm not familiar with it at all. And so we do have the ability to cross-check some of the medications, the active ingredients through, through these work-related, so resources, and so we can see if it's safe if we're familiar with the active ingredients. But I've actually seen a lot from other countries that I'm not familiar with, so it's definitely depending on the patient, what they're currently on, but you have to bring the item in for us to be able to cross-check it.
So there's been a couple questions about DBS and its impact on sleep.
I don't have a particular trend that I see with DBS and sleep disturbances. So I don't know what the question is, like in referencing if DBS has negatively impacted your sleep or positively impacted. I'm not sure in what context.
It was just, does it affect sleep? I've heard that for some people it actually can improve sleep because symptoms were improved.
Yeah, so I think if you I see it in that aspect, yeah. So if DBS is helping with your stiffness, with your tremor, so if your motor features are improved, you're able to reduce oral medications, that tends to also positively impact your ability to sleep as well. So I can see that DBS is usually seen as more of a positive feature for sleep and not negatively impacts it, but I really haven't seen a negative trend.
And we're almost out of time, but I think we have time for this last question because it was on one of your slides, and I think that people probably could evaluate their home environment to maximize their sleep. So what are some of the suggestions to set the stage for their best night's sleep?
Sure. So I think it kind of depends too. Like I've had patients so I live in Las Vegas, the clinic's out of Las Vegas. So we get a lot of shift workers here, people in the industry that are used to staying up all night and working during the daytime. So it just depends on what your pattern of sleep has been. So if you can, I would always recommend, like, those blackout curtains, providing a really safe place to sleep. I've had patients moving the taking away the bed and putting the mattress just on the floor. So there's no way that they can fall out of bed when you can't eliminate REM behavior disturbance at all. So again, if you're going from 5 or 7 episodes a week to 1 or 2 episodes a month, if it's still happening and you want to protect yourself and your bed partner, then getting a bed rail, moving the mattress to the floor is always helpful. But even things like, gosh, the nightstand is, I feel like, always so dangerous. The sharp edges of the nightstand is what we hear the most, is people bumping their heads and falling, diving out of bed and hitting that, or falling in between the bed and the nightstand. So maybe eliminating the nightstand and keeping, fewer items next to the bed would definitely help.
And I think, and I can't remember if I read this on your slide, but I know I've seen it before, in terms of like sleep hygiene, like maybe removing lights in their rooms that could be disturbing, like the blue lights. I know I can't have any kind of blue light in my room. It drives me crazy. Maybe lowering the temperature of the room, making it cooler so they don't get hot, things like that. So any other additional suggestions?
Yeah, I agree, Anissa. I think those are actually really great suggestions that you brought up as well with patients. Is really depends on their symptoms too. Is if they, patients with Parkinson's, again, with autonomic dysfunction, sometimes come in and complain that they get really hot during the night. They sweat a lot more, and so being in the right clothing articles that for sleep, in the right bedding helps. And just being in a cooler environment, lowering the temperature of the room, eliminating any light and distraction, your phone and TV, even the radio. I've had patients say that those things are really distracting. Or even daytime things in the environment that stresses you out that will impact your sleep, like watching the news and everything that's going on in the world. I think if it negatively impacts your emotion, then that can impact your sleep. So I would say reducing those stimulus.
And related to that, and this will literally be the last question we have time for, but
Yeah.
I think it's something that relates to a lot of people, is if they're waking up and they're up for 3 to 4 hours a night, should they fight to try to go to sleep or enjoy a movie? Or is that counterproductive?
I think it depends. So, like, if the patient, obviously, if you're retired and you don't have to be anywhere at 8 a.m., and you are able to make up the sleep in some way later in the day and you feel restored that way, I've had people say it's no problem at all. I wake up, I just go, clean the house or watch a movie and then go back to sleep. But I would say trying to keep that pattern of sleep, in the evening time is so important. If you can, so if you're using melatonin for sleep, for example, you can ration that. You can take half of melatonin before sleep and the other half when you wake up during the night. And I know some stores will also have the sustained release formulation of melatonin, and so that gives you, a longer half life, and so it's better to use overnight. Yeah, I would say it depends. If you can, we always want to encourage, continuous sleep during the night and not fragmented. Because if you're waking up and you're staying awake and then sleeping from 8 a.m. to 12 noon, then again, it's not very easy to track like REM sleep.
Awesome. Well, I want to thank you so much for sharing all of this information. It's always important to have this discussion about our sleep because we all need it and we all at times struggle with it. So thank you for sharing your expertise and being with us today. And I want to invite everybody to give you their wave of gratitude. It's our way of saying thank you for joining us and for sharing your expertise.
Thank you so much. It's such a pleasure. Thank you so much for having me. Please have a safe day.
Absolutely. Everybody enjoy the rest of your Monday. Take care.